Hi, everyone, and thank you for the opportunity to speak to you today about our experience with large-scale clinical lab testing with the TaqPath COVID-19 assay. I'm very pleased to tell you what our experience has been, so let me go ahead and get started. First, I want to kind of explain to you what Clinical Pathology Laboratories is. We're part of Sonic Healthcare Worldwide, which is an Australian-based parent company with operations in Western Europe, Australia, New Zealand, and the United States. Sonic has been obviously a global response partner to the pandemic as it has swept across the world. And each of our countries has responded as their populations needed the test services that we offer. Within the United States, Sonic Healthcare US is a federation of laboratories, each serving defined geographies. We have about 9 regional laboratories with various test sites across slightly over half the country. The sites that you see in blue are large reference laboratories that serve large populations in high throughput lab settings. The map pins that you see in orange would be regional stat laboratories or anatomic pathology laboratories. Clinical Pathology Laboratories has been in operation for more than 70 years. They were one of the first laboratories in Central Texas. They brought near real-time or next-day service in anatomic pathology. Very early on, they were the first to bring the Pap testing services to Central Texas in the 40s and 50s. And at this point, we've grown with the area, and we're an intimate part of the community. We now expand to 8 states, Texas and surrounding states, and we serve virtually every laboratory need that people would have. So we have departments of microbiology, chemistry, cytology, histology, microbiology, and molecular testing. We have a very mature operational force, so we have courier networks that span our geographies, so we can very efficiently bring samples into the laboratory for testing. We also have mature customer service operations that are local to the geographies that they serve. And we have a centralized exception handling department so that as exceptions come up, which they always do, we can respond to them quickly to provide the best we can in patient care. So the outline of my talk will be to tell you a little bit about how we've implemented the TaqPath testing here at Clinical Pathology Laboratories. I want to paint a picture of what the workflow looks like because the TaqPath assay looks fairly different from what a high-volume reference lab or hospital lab would normally see. I'll talk to you a little bit about the quality control and pathologies of this assay and what some of its operational characteristics are now that we've been in operation for several months. And then, we're all interested in how the pandemic is unfolding. So I'll show you some comparison to antibody results, which I think are just interesting and, self-validating in the overall testing paradigms that we serve. All right, so moving into how we've responded at Clinical Pathology Laboratories, we, like I think every laboratory in the country, have been very active since the March timeframe to bring on testing. Our first test that we launched here was March 11th with the Roche Cobas assay. We launched IgG serology testing in April. We did a lot of work with the TaqPath assay before the 384-well version was FDA cleared under the EUA approval process. We had developed a laboratory developed test at 384 because we recognized that demand was going to far outstrip capacity unless we moved to a 384-well platform. So we launched in April with that and our own EUA submission. And then we're very pleased with the progress that Thermo Fisher made at expanding their EUA, and we're able to go back to their IFU based methods as those launched. Then that expansion continued in May, where we launched a total antibody assay for SARS-CoV-2. And then in June, we've also launched on the Hologic Panther platform. So we offer at this point 3 different platforms for nucleic acid testing for SARS-CoV-2, the Roche platform, the Hologic platform, and the Thermo Fisher COVID-19 assay. All right, so the basics of this assay, as you may already be aware of, specimen collection follows routine collections that you would have for upper respiratory specimens. The instructions for use are fairly broad: nasopharyngeal, oropharyngeal, nasal, and mid-turbinate swabs, as well as nasopharyngeal aspirates. and bronchoalveolar lavages. We don't see very many of those anymore. Most of the screening now is, most of the testing now is nasal based, as that's the recommendation from CDC. So specimen collection handled primarily by our clients, although CPL operates a variety of patient service centers in the territories that we serve. We do not collect respiratory specimens because that requires specialized training and expertise and PPE and environment that is not normal for a typical blood collection. So specimens arrive here at the laboratory under controlled conditions appropriate to the stability of the specimens. And then the first step of the extraction process is using the Kingfisher platform and the MagMax viral/pathogen nucleic acid kit. We have migrated onto the version 2 of that kit, and we're using Kingfishers for all of that extraction. And then in the analytical assay itself, the RT-PCR is simultaneously detecting 3 different targets, plus 1 exogenous control and MS2 phage control that is spiked in prior to extraction to verify the extraction on each sample. So those are the basics of the assay. As we map the assay onto a typical clinical workflow, many of you in the clinical space are familiar with the stages of clinical testing: pre-analytical, analytical, and post-analytical. I'm kind of leaving off pre-analytical and post-analytical out of this discussion. Great many steps in each one of these, and the reason I wanted to put this up here is, first of all, to say, the Roche, the Thermo Fisher assay is really the yellow box in the middle, right? The sample prep, extraction, qRT-PCR setup, analysis, curve review, and release. But the steps that a lab like CPL really focuses on a lot have to do with pre-analytical, because you can find many published studies that say that the majority of errors or mistakes that happen in clinical testing are often pre-analytical, a specimen being incorrectly labeled with respect to who the patient was or incorrectly collected. So we do a lot of work in all of our systems and processes to both give clients feedback when we spot errors, get those errors resolved, and then continuously educate them. So these different steps are, of course, independent in the pre-analytical step from the testing platform. So on the left-hand side of the screen here, you see the detailed steps to the Thermo Fisher TaqPath assay. And on the right-hand side, you see what would be a typical workflow for the Roche or Hologic platforms. The Roche or Hologic platforms are large-scale automated platforms designed for clinical testing, from the ground up. They've had FDA clearance for tests like viral load for years now. And so while they're analytically much more straightforward, a technician is just loading sample and reagents on the instrument, and then coming back later for a QC review and review of the interpretation and release. All of the precursor steps, the pre-analytical steps are basically the same, and the post-analytical steps are basically the same. We have to provide support to our physician clients for result interpretation, right? If there's so for example, if a patient's particular course, they present with the types of manifestations of a COVID infection, and then they get a presumptive positive result back, for example. Or in the Thermo Fisher workflow, you have an inconclusive, and then you're, according to the package insert, going to retest that inconclusive again and give a report out, and it may be genuinely inconclusive. So we need to be able to help clinicians understand and interpret that in the context of a patient's disease progression. And that's true across all the platforms. The other point I wanted to make on this graph, though, is that you see there are a great number of steps in the Thermo Fisher path, more than on the Roche or Hologic side. And to be frank, I think that's one of the powers of the Thermo Fisher assay, and one of the reasons they were able to scale up is that each one of those steps could be managed independently, where the large monolithic platforms, if you just have a single step or a single reagent or a single pipette tip that is a limiting reagent, you are unable to expand those platforms. And in fact, that's been a struggle, across the molecular space as the pandemic has unfolded globally. But Thermo Fisher, in our experience, has done a very good job of not having supply constraints or being able to, source alternate materials like they did moving from the MVP1 to the MVP2 kits for the extraction process. But that puts a little bit more complexity back on us to manage each one of these separate process steps. As we operationalize the assay, obviously we're looking for as much automation and control as possible to ensure a quality result with every specimen. Part of that is done by training. So we spend a lot of time training each technician. As we've had to scale up this, not only are we scaling up the materials, we're scaling up the labor force required. And so we spend a lot of time on training. We spend a lot of time on understanding where are key control points in the assay that will give us an indication as to the quality of the assay or the quality of the results, so that if something goes wrong, we can catch it, intervene before the result is released out to the physician or the patient for action. The other thing I'll point out that especially early on was a critical bottleneck operationally for both of these assays, both the automated platforms and the TaqPath platform, is the step labeled aliquot, where we're moving the specimen out of the primary collection device into the device that the testing process requires. In the case of TaqPath, of course, that's a 96-well plate. In the case of the Roche or Hologic platforms, that's a dedicated specimen analysis tube that's designed for the automation platform. The only other difference between the two is the batch building process. Obviously, TaqPath, being oriented around microwell plates, requires you to group specimens into some type of batch. That's not unprecedented in the clinical laboratory, but is obviously a critical step when we're trying to track specimens. It's not infrequent that a batch of specimens may come in and then the patient's condition changes. Say they're a hospitalized patient, and we need to be able to quickly identify which batch is that patient's specimen in and estimate for the client when we'll have a result out to them so that they can make clinical decisions. So we built some custom workflow elements to track that batching process so that we could respond quickly to client requests and be able to track specimens well. All right, that's, I think, the crux of the comparison in the clinical workflows. Now I want to give you a little bit more detail about some of these steps in the analytical workflow comparison. On the Roche 6800 or 8800 platforms or the Hologic Panther, it's really fairly straightforward. The aliquoting steps are about the same as between the TaqPath method. The TaqPath method takes a little bit more care, obviously, because instead of going from a single tube to a single tube that you're doing on the 6800 or the Hologic platform, you're moving from a single tube into a well of a 96-well plate. And so, again, we spend a great deal of time on staff training and methods to ensure that the accuracy of that transfer is high. The automated platforms, come pre-kitted with fairly large batch sizes, 250 or 192. And both instruments are basically continuous load. So we can have our specimens ready, aliquoted, and just continuously load the machine with both reagents and specimens. And then the results automatically merge into our LAS. On the TaqPath side, it's a little bit more batch oriented, again, because it's tied to a 96-well plate. So we perform the aliquoting into 96-well plates. We do what I would call a sample pre-preparation to combine the specimen with proteinase K, a bead binding buffer, and the MS2 internal control. That's done on a Biomech FX or a Biomech i5 in our case. And the output of that process is a single 96-well plate that's ready to go on to the Thermo Fisher Kingfisher instruments for extraction. The Kingfisher instruments are very straightforward. They're loaded with the specimens that are pre-prepared, as I just described, along with 2 wash buffers and an elution buffer, and the tip comb that's required for that magnetic bead extraction. Those go onto the machine. They're very reliable. In our experience, 23 minutes later, you have extracted RNA. We then take batches of 4 of those 96-well plates and plate them into 1 through 84-well plate. We use either manual or automated 96 well pipetters. There is one step that's a little bit inconvenient to be able to add a manual kit control at that stage. There is one control that's required per the instructions for use as a positive control that is post-extraction. So that's added at that point. If you were to tally up the times here, well, I should continue on. So you run the qPCR 70 minutes, but only 5 minutes of that is hands-on time. And then there's maybe another 5 minutes after the run to QC the results, check the curves, transfer the analysis file, use the COVID interpretive software provided by Thermo Fisher to generate the clinical interpretations and upload those and release those into the LAS. So it's a straightforward linear workflow, not a tremendous amount of hands-on time, more so than the automated platforms. But at the same time, if you were to look at throughput or even throughput per FTE, it's quite a high throughput platform. We're able to produce a large number of results. And again, unlike the automated platforms, the ability to add incremental capacity is much more straightforward, especially once you have a trained workforce and your procedures and process and environment are set up appropriate to the testing. All right. So if we were to look now again at throughput, and these are just sort of nominal examples in our experience, so they may or may not match exactly what the vendor specifications are for the devices, but this is sort of our practical experience. A single Roche 8800 can produce about 3,500 results per day with 1 FTE per shift. So we've been operating 3 shifts, 7 days a week, pretty much since the pandemic started. So multiply, that 3,500 is divided across 3 shifts per day. A single Hologic Panther can produce about 750 results a day with 1 FTE per shift. And that single FTE on the Panther or the 800 actually probably has enough time to be able to staff additional instruments in those cases. If you compare that to sort of what I would call the minimal implementation of the Thermo Fisher TaqPath assay, that would be with 2 Thermo Fisher 3D 4-well QuantStudio 7s with 3 of the 96-well Kingfishers. That's sort of, in our experience, a rate match between those 2 instruments, assuming 0 downtime for all those instruments. That system can produce about 12,000 results a day, but requires about 9 FTEs per shift. So much higher demand on labor, but obviously much higher throughput as well. All right. Quality control. So as I mentioned, taking any FDA-approved test and implementing it in the laboratory is always keenly concerned with what are the quality control points of this assay in our environment so that we can assure a quality result for every patient. The instructions for use from the manufacturer are quoted there, and I apologize, they're in fairly fine print, but it, as many package inserts do, is a little vague. It says a minimum of 1 negative control and 1 positive control must be present for each run. Additional negative control wells must be run for each extraction that is represented on a real-time PCR plate. And then, of course, all the control wells must pass. And the COVID interpretive software will actually invalidate either individual results or the entire run based on the results of those QC. Well, we had a few concerns about that because, as you would imagine, in a batch process like this, we're taking 4 96-well plates that had each been separately extracted, combining them into 1 384-well plate. And then every single well, of course, has the MS2 exogenous control added to it. So if you follow that through strictly, there is no true no template control. Every task NTC that we designate is expected to have MS2 in it. The manufacturer provided positive control that's a post-extraction control does not have MS2 in it, but there's no well on the plate that has nothing in it, where you would expect no amplification. And obviously, if, in a worst case scenario, if MS2, the exogenous control, were to somehow contaminate master mix, basically there's no explicit control for that. So we went ahead and defined locations where there is a true no template of any sort, including MS2, is added, and we verify that there is no amplification in that well as well. The second thing is that the instructions for use and the IS in this case stands for the interpretive software. They both rely solely on the positive control, which is a post-extraction control, and it must not contain MS2. We like the idea of having a positive control throughout the process so that we can detect, for example, if there could be any issues in reduced sensitivity related to, extraction issues, if an instrument's temperature control were to be varying, or any other minor process problem, whether related to equipment or reagents or personnel. So we went ahead and added positive controls to every 96 well plate, in addition to the recommended negative controls in each 96 well plate. The other thing we note about the assay is that while we overall are pleased with the stringency of the interpretive software's evaluation of QC, it offers no direct support for individual 96 well plate quality control. It tends to either fail or pass the entire 384 well plate. For example, if any no template control in the 96 well plate is non-negative, it fails the entire 384 well plate, and the interpretive software offers no explicit support for a positive extraction control. So we've gone ahead and added those elements so that our technicians can more readily evaluate both on an individual batch basis the quality of the positives or the negatives on an individual 96 well plate. This also enables us to do longitudinal tracking of positive controls, which the interpretive software does not support. Large clinical labs are very accustomed to looking at LJ charts, for example, in a chemistry department, where you're looking for stability of the assay over time, so that you could detect shifts or trends, biases that may be coming into the assay. Again, in a molecular context, typically, especially a molecular context where the test is a qualitative test, it's usually easy to spot when things are very bad, right? Your positive controls go negative or your negative controls go positive. But having longitudinal ability to look at positive controls, we think gives us an additional level of comfort, of stability, again, of process, people, equipment, across time. All right. I've pretty well described everything that is on this. We do monitor each 384 well plate for a true no template control. We not only add one, we actually add two positive controls, and I'll explain why in a few slides. That enables us to look for possible rotation of the 96 well plate. In the Thermo Fisher processes and in many 96 well plate oriented processes, one can rotate the plate because the plates are not keyed generally to their orientation, and it can be a very difficult to detect failure or problem. So by adding two distinct positive controls, each with slightly different expected CT values, it gives us an enhanced ability to detect for an inadvertent rotation of a 96 well plate in the process. We do assess extraction controls throughout the process, and we watch batch positivity rate. We have found across all platforms, the Roche platform, the Hologic platform, and the TaqPath platform, over time, that watching positivity rate is probably one of the best measures of individual batch quality, and lets you very quickly assess if something's gone wrong in a batch. All right, we did build effectively a lightweight middleware using the R programming language to support these QC functions, and some web-based tools that enable our technicians to interact with and understand what the QC is of every batch as they move along. All right, now moving on to pathologies. This is an example, a screenshot of one of those QC tools that I mentioned. It basically is a simple heat map that just shows positive, negative, invalid across the entire 384 well plate. In our case, our 96 well plates are interleaved. So for example, the 384 well quadrant A1 is our alpha plate, our first of the 4 plates. A2 would be the second. B1 is the third, and B2 is the fourth. So when you see a pattern like this, in this case, yellow represents positive results, red are invalid, and gray are negative. And you see these striking bands at the edges of the plate, that there's just a lot of positives. And this is an unusually high positivity rate, so that would be flagged immediately. And in fact, when we went back, the technician caught this at the time. We went back and looked at the plate, and indeed the adhesive seal that's applied to the 384 well plate manually before it goes into the real-time PCR machine had not been sealed well at the edges. And there's a very aggressive vortexing step that's required in this assay immediately prior to RT-PCR to ensure that the RNA template and the master mix are well mixed. And so by not having those seals at the edges of the plate, there was just enough positivity to bridge across. If you have an adhesive seal that's not fully sealed, it becomes a wicking bridge to transport sample. And so we believe that's what happened in this case. So easily caught, easily understood, easily fixed operationally, and not released. So this was rerun before being released. All right, another few pathologies that are easy to spot at this level. You can see the right-hand graph. Now I've shifted the key. In this case, now purple is positive, yellow is negative, and gray are invalid. And you see this clear checkerboard pattern in the right-hand panel of gray wells. And that was an indication that, in fact, in a manual step, a technician just simply did not add MS2 to a 96 well plate. Operationally inconvenient, but no risk to quality of results because it's easily spotted and flagged. Again, in our middleware, we would flag this level of MS2 missing. The panel on the right actually shows just a small run of those gray wells, indicating that possibly a row of pipette tips at that row on one particular plate did not have good seal, or maybe there was a bow in the plate, or the source plate for MS2 was under volume. It's difficult to know exactly what the root cause of that was, but it's almost certainly something related to pipetting. So these plate level views are invaluable to spot pathologies in the process. The other thing, as I mentioned, we look at are positive extraction controls over time. And I mentioned we use 2 different extraction controls. Positive control 2, showing box plots of both 1 and 2 in this graph over time. Positive control 2 in the lower panel is a 1-to-4 dilution of positive control 1. So you would expect a 2 CT shift upward in those controls. You will see step functions. So somewhere around, I don't know, July 25th or so, we changed control lots, meaning we made a new batch of the extraction controls. We actually make these extraction controls from previously tested high patient positives that are diluted down, so that they are higher in CT values, so they're a fairly sensitive positive control to any issues that may be impacting sensitivity of the assay. And then again, somewhere around, I would say, August 20th or so, you see a shift up in the CTs as we changed lots again. So, it's easy to, obviously we document the changes of the lots. It's easy for the supervisory staff to look at these and ensure that, the assay itself is not shifting performance over time. I've bracketed CT values of 25 and 30 just arbitrarily so you can get a better sense of where the medians and the interquartile ranges are for the PC values. The other thing I'd point out, which is something we're generally pleased with, is how tight the data is. So the method tends to be very reproducible. And within a lot, we tend to see very good stability over time. Some of the data points off to the right-hand side of the graph where you see a little bit more variability. Interestingly, and I'll get to this in a few graphs, our volume has gone down. So there's a little bit more variability just associated with reduced volume over time. And that's just a factor that you just have to keep in mind. All right. The next thing I wanted to go over was I had mentioned this, the fact that we use these extraction controls also to detect possible plate rotations. As an example, every 3D 4-well plate, which is the panel you see on the bottom, is comprised of 4 96-well plates, and you see what we call an alpha plate and a Charlie plate on the top. There is a Bravo and a Delta that's obscured right now by the 3D 4-well plate. In each of the Alpha, Bravo, Charlie, and Delta sets, 2 positive controls and a negative control are located in different positions in the plates. And where they wind up on the 3D 4-well plate is shown in the bottom panel. So for example, the positive control 1 on the alpha plate is in well B1. That winds up being in well C1 on the 3D 4-well plate based on how we interleave them. And similarly for the Charlie plate, positive control 1 on a Charlie plate is in well, let's see, that would be A10. And it winds up on the 3D 4-well plate in well B19. So if an Alpha, Charlie, Bravo, or Delta plate were rotated, this pattern of controls of positive control 1, negative, and positive control 2 would appear in defined locations. So we have an algorithm that goes and looks to see whether that pattern appears where it should not appear and confirms that it does appear where it's expected to appear. So that's part of our quality control process. There are many ways to solve this problem. This is just one that we found operationally straightforward to implement. Okay, now I want to go on to talk about pathologies of the individual assays and amplifications themselves. And some of this data was kindly provided by Thermo Fisher. One of the updates to the instructions for use that came out fairly recently within the last month and a half or so was the importance of vortexing the 3D 4-well plate. As I mentioned, the extracted RNA has to be mixed very well with the real-time PCR master mix and probe and primer mix. The viscosity of the master mix is very high, and so it's very important to vortex this very thoroughly. If you do not do that, what you see in the very early cycles of the assay, as the temperature fluctuates, the temperature itself, the convection, is actually driving mixing. And so you see some changes in the signal in the first few cycles as the assay is mixed thermally. Had it been mixed through vortexing, this background in the first few cycles would be flat. So this is something that's fairly easy to pick up on is now part of our standard curve review. If you look at an amplification plot, again, you would see this substantial amount of background in the first few cycles as evidence that the plate was not well mixed. So package insert now says not only vortex this very carefully, but also check the curves of every run to ensure that it has in fact been well mixed. All right. Other examples of irregular curves that may occur, for example, if there was an inhibitor or some other methodological problem went wrong. The upper left graph shows a great amplification curve, clear exponential amplification, meaning a nice linear region in a log plot, in this case of all 4 targets, so things working quite nicely. The graph to the right of that says not true PCR amplification, you see a few amplification curves that are shaped exactly as expected, and you see others that rise abruptly and then have a sharp elbow and a long drift cycle. That is not true PCR amplification and may have something to do with irregular background in early cycles, or may have something to do with another unusual reaction condition. Bottom left, not true PCR amplification. With high background, you can see these what we call lazy curves that are rising slowly over time. And to the left, you see that the background in the first few cycles is nearly the same level of the curves during amplification. And then bottom right, you see quite a sporadic signal, almost a sawtooth pattern in some of these, which again, may be related to an instrument issue, an electrical noise issue, or something related to the assay. But these are not real curves and merit further investigation before data like that would be moved forward for release. Okay, so that expands on some of the pathologies. Now I want to get into looking at large sets of data that we generated over the last several months. So with over 100,000 data points, it's always interesting to look at the three targets that are in the assay. There's the N gene, the S gene, and the ORF1ab region of the SARS-CoV-2 genome. And so I've plotted here sort of a two-dimensional density plot of the CT values of these various targets. And so this would indicate, for example, if the N gene CT is, well, I'll say it this way, if the S gene CT is slightly higher than the N gene CT at the same sample, then it would suggest that the N gene is slightly more sensitive at detecting SARS-CoV-2 than the S gene. So that's this little kick up that you see at the very end. But overall, very near linear throughout the dynamic range of the assay. N versus ORF1, again, very similar. S versus ORF1, again, pretty similar. You might infer from this that, N gene is the most sensitive, ORF1ab is the next most sensitive, S is probably the least sensitive of the three, but still valuable across time. You'll also notice something this struck me when I was putting this data together, that there's a bit of bitomodality. You'll see there's a bit more concentration down here in the low CT ranges, so these would be, we would call this high viral load, although we would hesitate to say that a nasal swab is an accurate way to capture a viral load. But certainly within the assay, this is a lot of virus in the CT values between sort of 15 and 20. And then there's another peak up here in the around 30 CTs, and we'll expand on that in the next slide. So this was 100,000 data points taken over several months. If I now look over time, I'm showing you that same data, but by week of the year. So week 23 was June 1st, the week of June 1st. The last panel on this graph, week 34, was August 19th. So as you'll recall, and certainly within the geographies that we serve, Texas and the Southwest, the pandemic was really creeping back up, post Memorial Day. And so we believe, the data suggests that there were very many high viral loads in these first few weeks of June, going through all of June. And then starting in sort of July, we had a lot of people testing. If you might remember from the popular media, there was an absolute surge in demand for testing in a few weeks in July. And so as that surge occurred, you see this bimodality emerge, where we still have some very high positives, but we also have some very weak positives represented by the peaks at higher CT values up around 30. And in fact, that trend just continues. And so now the majority of the peak is actually at CT values higher than 30 as of the week of August 19th. To expand on that story a little bit more, what we've seen sort of from an epidemiological perspective, positivity rate, at least in the Southeast, really blossomed. So this graph shows you, by date positivity rate. So I've drawn lines at 10% and 20%. Starting just after July 4th, we pretty consistently went over 20% positive in the samples that we were testing. And then as we expanded into August, that positivity rate dropped back below 20%. And in fact, today it's back down below 10%. But as that positivity rate followed that course, the CT values that we see, just the average CT values, these are box plots of CT values, tended to drift up. And this might suggest that, for example, either people who were suspicious of disease and catching it earlier were being tested, or people who perhaps had the disease and now were in late stage and wanting to confirm no residual nucleic acid existed, were coming back to be tested. Unfortunately, as a laboratory, we don't really get to understand every patient's clinical trajectory, so I can't easily tease those apart. But the data certainly suggests that there were a large number of people being tested perhaps late in an infectious state or after they had already had acute disease. The other story here, of course, is that while we're very pleased with the TaqPath turnaround time and capacity, it still is only a certain amount of capacity. So the huge demand that erupted in June, you can see that's when the positivity rate started to spike up. And our turnaround times, we try to maintain turnaround times well under 48 hours because that's the most useful turnaround time for the test, is as fast as possible. But once you're completely, the testing demand far outstrips the capacity of any laboratory, and this was every laboratory in the country was being outstripped at the time, the turnaround times by necessity increase. But since then, you can see they've been quite low and stable. All right. The final sort of interesting clinical picture here is to look at, as I mentioned, we do antibody testing as well. So in some cases, I was able to find patients who we had tested with the TagPath assay and later tested with either the IgG antibody or the total antibody, and I haven't discriminated between the two. And I'm just asking the question, sort of, does biology work? So this is looking at patients who had positive antibody tests that were more than 2 weeks after an initial nucleic acid test that was also positive. And we're just asking the question, what do the CT values look like? And you see the CT values are broadly distributed. There's this sort of bimodality to it. I wouldn't put a whole lot of faith in that because, as I recall, there's not a huge amount of data in this. But it does indicate that, people who were acutely infected at one point with perhaps a very high CT did develop an antibody response. If I now change the question slightly and say, show me patients who had a positive nucleic acid test and a later antibody result, but it was less than 2 weeks after. So perhaps they did not develop fully an immune response in between the two tests. You see that their CT values are consistently only very high. And this suggests to us that these are patients who were tested by nucleic acid very early in their infection, right, when they were had very low viral load, and the time between the detection here and the antibody test was too short. Their immune system had not actually developed detectable levels of antibody. So the story here is that COVID does follow traditional infectious disease routes, and we see both the nucleic acid and antibody responses that you would expect. All right, so that's it. I would be happy to take any questions, and thank you again for the opportunity.